Hello, Dr. Udianto, I can see you. Hello, Professor Seno, I can see you.
Selamat siang,
Selamat.
Dr. Rashid. Terima kasih atas kesediaannya siang ini.
Terima
Apa
kasih.
kabar?
Baik, Alhamdulillah.
Alhamdulillah. Kondisinya agak mengkhawatirkan ya akhir-akhir ini.
Yes, that's right.
Ini masih ada kesibukan pagi rupanya
Yep,
dengan pasien.
I'm in the office. Saya masih di office sekarang.
Oh,
Baru
aduh.
aja. I miss the people in Surabaya.
Yeah, we are too. I think last time we met in Jakarta, right?
Yeah, that's right.
During Pertemuan Ilmiah Nasional
Correct.
Pediatric Dentistry.
Yes.
And I'm so sorry that we cancel the meeting in Korea
Yeah,
of
that's right. I think most
PDAA.
people were looking
Yeah,
forward to it, right? I don't know how's the situation in Indonesia now, but in Singapore, I think we're seeing very low numbers of infection in the community. But I still work with my N95. Yeah. Are you still working? Is everyone still working, or are you still seeing patients?
yeah. I think it's still dangerous for us in Surabaya because the case is increasing,
It,
tend to increase every day. So we still worry about it.
is it easy to get N95 masks in Surabaya?
I think so, yes, but not. I think even it's easy to get one, but it's still a high risk for us to do the treatment.
I
So
understand.
only us in hospital that do the treatment and specific place that prepare for the full APD or to make penggunaan alat berlindung diri.
Yeah.
PPE.
PPE.
For the
Very
PPE.
tough times.
Yeah, I think it's time now, Dr. Tanya.
Ya, ya Dr. Udi. Dr. Ashita here, hi.
Hello.
Hi again.
How are you?
You look fresh. So,
Hello, Dr. Rashid.
ada Dr. Seno Pradopo.
Hello, Professor Seno. How are you?
Fine, thank you.
Good to see
How
you.
about you, Dr. Rashid? Welcome to Faculty of Dental Medicine webinar.
Thank you. Thank
How
you.
about Singapore now?
Singapore has
Yeah.
very low numbers of infections in the community. I think yesterday was the lowest number in the last 6 months.
Happy.
Of course. And
Indonesia still high.
I'm in my office now. You can see the background. That's my waiting room.
I see. Very nice with greenies.
Thank you.
So I think it's time for us to start the SOS meeting today. So we have Dr. Ilvana as the master of ceremony. So you can start, Dr. Ilvana, please.
Thank you, Dr. Tanya. Good afternoon, Dr. Asid.
So,
Okay. Let me start our lecture today. Assalamualaikum warahmatullahi wabarakatuh. Maybe before we start our lecture today, let me introduce myself first. My name is Ilvana and I will be your MC today. And selamat siang kepada kita semua dan good afternoon to the Dean and Vice Dean Faculty of Dental Medicine, and also good afternoon to all of professor and all senior and colleagues and also all student and resident of Pediatric Dentistry. And then thank you all for finding time and visiting today's lecture. Maybe before we start our lecture this afternoon, let me reminding to all of you to mute the speaker and put the camera on. And also I reminding to all student and all resident to rename our username of Zoom, and don't forget to present according to the link we have set before. Jadi dimohon kepada seluruh mahasiswa dan juga seluruh residen jangan lupa untuk presensi sesuai dengan link yang sudah kami sampaikan sebelumnya. Dan juga dimohon kepada seluruh partisipan untuk menyalakan videonya. And just for your information, that today our Zoom capacity room limited only to 300%. So I hope all the students and residents to join us as soon as possible. If you cannot join with us in this room, you can see our lecture in YouTube live in Dental Medicine Erlangga channel in YouTube. Maybe before we start our lecture, please welcoming our great speaker today, Dr. Rashid. Good afternoon, Doctor.
Good afternoon.
How are you, Doctor?
I'm good, Alhamdulillah.
Thank you, Alhamdulillah. Welcome to Pediatric Department of Dental Medicine Erlangga University, Doctor.
Thank you.
Okay. Dr. Rashid, here is it. There is a short greeting maybe for our senior pediatric of dentistry, Prof. Seno, Dr. Gigi, Seno Pradopo, SU, PSD, SPKGN Konsultan. Prof. Seno have joined with us. Prof. Seno, good afternoon,
Thank
Prof.
you. Okay.
Yeah. Time
Good
for your...
afternoon, Dr. Ashita. Thank you and welcome to my webinar session. And I hope you still happy and health for the give me time for your lecture today. And then please now time for yours. Thank you. Return to the host.
Okay. Thank you, Prof.
Ya, Pak.
Seno. Yes.
Thank you.
Thank you. And please for one more welcome greeting, Dr. Rashid, for our Head of Pediatric Dentistry Department, Dr. Gigi Udianto Tejo Sasongko, PSD, SPKGA Konsultan. Dr. Udi, please welcome greeting for our great speaker today. Time is your doctor.
Terima kasih, Yovana. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang semuanya, khususnya Dr. Rashid Tahir. Senang sekali bisa bertemu walaupun kita harus bertemu secara virtual ya, Dokter. Juga kepada para pimpinan FKG UNER, Pak Dekan, para wadeknya, Wadek 1, 2, 3, dan para senior staff dari Fakultas Kedokteran Gigi UNER. Selamat siang. Siang ini kita sangat beruntung bisa bergabung dan mendengarkan ceramah atau kuliah dari Dr. Rashid Tahir mengenai bagaimana behavior management pada pasien anak di ruang praktek. Dr. Rashid Tahir, saya sampaikan bahwa peserta ini sebagian besar adalah mahasiswa program profesi dan program S1 undergraduate dari Fakultas Kedokteran di UNER. Juga ada residen dari program spesialis kedokteran gigi anak. Selebihnya adalah staf pengajar dari FKG UNER dan para alumni. Terima kasih atas perkenannya karena keterbatasan Zoom kami. Mohon izinnya Dr. Rashid untuk kita juga share melalui YouTube acara hari ini. Sekali lagi terima kasih atas kesediaannya. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Rudi. Maybe we can start our lecture this afternoon about behavior management in dental office by Dr. Rashid Tahir and also Dr. Tanya Saskianti, SPKGA Konsultan, as the moderator today. Dr. Tanya, are you ready, Doctor?
Okay, thank you.
It's yours, Doctor. You're welcome, Doc.
Dr. Rashid Tahir, welcome again.
Thank you.
It is very hot afternoon in Surabaya. maybe you cannot feel that hot since it's very comfort with the air conditioner. So for today's session, you will be uh, give the lecture about the behavior management in dental office. I previously I would like to thank you for you, of course, to become our distinguished lecturer today. Thank you also to Dr. Udi to contact for contacting you, and also for your time today, because I know you are very very busy actually on this Saturday for treating your patient. Thank you very much once again. For today's lecture, maybe you have 60 minutes around. So this is the not so tight schedules, Dr. Rashid Tahir. So you can present your presentation for about 60 minutes, and maybe 30 minutes after we can have the question and answer session. Or maybe do you like the question and answer session on the last session after your presentation, or maybe the student can ask you during the session, or how?
I think
What?
it's going to be divided into slightly two sections. It depends. After the first part, maybe if you want to take some questions, I can take some questions, and then after that we go to the second part. So I split it up into two sections of the lecture.
I see. So maybe we can do all the presentation, and then we do the question and answer session after the two session. Is it okay, Dr. Rashid?
I mean, we can work both ways. I will stop at certain point, and then if you have questions, I'm happy to take. Or we can take everything at the end of the session. It's okay.
Thank you. And then would you mind if we do the mix bahasa Indonesia, bahasa Inggris, and
I I can understand a bit of bahasa Indonesia, no problem. But for me to speak bahasa Indonesia is going to be a big problem.
Okay, thank you very much. Okay, maybe before we start the lecture, I would like to read Dr. Rashid Tahir curriculum vitae. So Dr. Rashid Tahir is an adjunct associate professor at the Faculty of Dentistry, National University of Singapore. He graduated with BDS in Singapore in 1994 and get the MSc with distinction in Children's Dentistry from Eastman Dental Institute, London in 1998. And he is the immediate past president of the Pediatric Dentistry Association of Asia and had served on the editorial boards of the European Archive of Pediatric Dentistry and the Singapore Dental Journal. He was founding president of the Society for Pediatric Dentistry Singapore and is a member of the Dental Specialist Accreditation Board under the Ministry of Health Singapore. He chaired the Dental Specialist Accreditation Committee of the College of Dental Surgeons Singapore for specialist registration in pediatric dentistry from 2008 to 2017. And then now he maintains a private practice restricted to pediatric dentistry at the Kids Dentist located at Camden Medical Center, Singapore. Wow, it's very, very wonderful curriculum vitae, Dr. Rashid Tahir. So are you ready with the presentation?
Yes.
So maybe you can try to do the share screen.
Yeah, let me share my screen.
So if you are here with the non-pandemic era, we will take you around to Surabaya and
Yeah, I want to eat the rawan setan in Surabaya.
How come? Rawan Setan, you remember, in front of the hotel.
Can you see my screen now?
Yes, please, Dr. Ashita here. thank you, and you have your time and floor, please. Thank you.
Thank you. Thank you, Dr. Tanya. I hope you can hear me very well.
Yes,
Um,
I will.
so if you cannot hear, I hope someone will alert me. You can WhatsApp me, whatever. I have all my screens ready.
Okay.
Thank you for inviting me, especially to Dr. Udi and University Airlangga to this session. It's indeed an honor and a privilege. Just to let you know, again, I am a practicing pediatric dentist. You can see my office just now. I'm not sure whether you can still see it now. Um, I've been in private practice, restricted just to doing pediatric dentistry for the last 14 years. And each day, I used to see between 25 to 30 children in a day. One person seeing 25 to 30 children in a day. Um, and of course, we need to manage children very well. I think the only difference between us and any other dentist is that we are supposedly good at managing children in our dental office and getting them to cooperate with us for dental treatment. So the topic of my presentation today will be managing children in the dental office. And I would like to share with you the behavior management techniques and at the end, an action plan for you to carry out your treatment successfully. I think this is a beautiful picture, except for I have to put black colors on the children's eyes to protect the identity of this child. Um, this is a child who is attending the dentist at age 1. I think being pediatric dentists, we always want parents to bring children in as soon as the teeth erupt, or minimum 6 months after the first teeth erupt, and that's usually about age 1 years old. And it tells so much about this picture because you're doing a good preventive advice for a young child, and you manage a child when he or she is actually very young, coming to the office for the very first time. It's not I'm not sure whether it's always easy or not easy to teach about pediatric dentistry behavior management, because behavior management, basically these are the behavior techniques that you are commonly used to. If you are an undergrad or you are a grad student, you would have learned about tell, show, do. You would have learned about modeling. You would have learned about distraction. You would have learned about systematic desensitization, or positive reinforcement, or contingent escape, or voice control. These are common behavior techniques to be used in our patient. But if I were to just tell you this, that ends my lecture. And how long has it been? Only 5 minutes. Well, of course, it's not that easy. Knowing the behavior techniques does not mean that you can apply it correctly. So the more important thing is, if a child comes in to see you like this, covering his mouth, can you do your behavior management techniques? All the things that I've listed for you just now, would it work? I don't think so. Therefore, there are certain questions that you need to ask. Have you ever wondered what is causing this child to behave like this, coming into the office, being scared, covering the mouth, and then wanting to even talk to the dentist? Or coming in and having people to hold them down for you to actually examine. This is actually not, this is the mother, this is the mother, and this is the auntie. If you can see my arrows here. And my dental nurse is actually behind with her arms folded and letting them do what they want. So it's not always easy to apply the behavior techniques that you have been taught if the child comes in like this. You need to wonder why or how you could try to ease or make it easy for the child so that they are not scared, they are not anxious. And from there, you can actually do your treatment, right? And in young children, sometimes we get them to sit. See, this is obviously a very young child sitting on the parents, and you can actually do certain things on them and even treatment that may not be so easy in the first place. So knowing behavior techniques and knowing the child is actually important for you to be able to do good pediatric dentistry, even with local anesthesia and rubber dam, like in this case. So I hope you have also been thinking about what is the best way to manage children in the dental office. How do you avoid this? A child coming to see you and crying and being afraid, to becoming a child who can sit comfortably on the dentist chair, accept the local anesthesia, accept the rubber dam, and accept all the restorative treatment or even the minor oral surgical procedures that you're going to be doing on them. So to manage children in the dental office, you need to understand what affects their behavior during the dental appointment and the cause for anxiety or the behavior problems. Okay, so you need to understand what actually contribute the children's behavior so that they become anxious or they become good with you. Then you can know the types of behavior management techniques that are effective that you can apply to this behavior. So every one of us, if you have been taught a module on pediatric dentistry, you would have seen this pediatric dentistry triangle. It involves the relationship between the child, and the child is at the top of the pyramid. Okay, the child is at the top of the triangle. I can't find my arrow. Okay, the child is at the top because he's the king. He's the biggest customer, you know, because he's the one that is going to get the treatment. And then the relationship has to involve the parents and the dental team. And what's important in this triangle is that it has to be equilateral. It has to be equal on all sides, meaning the interaction between the child and the dentist, and the child and the parent and the dental team should be equal. So to understand how a child behaves, you need to understand the child himself. And there are four things basically that you need to understand about the child. Number one is about the age of the child, which tells you about the stage of child development. Number two is about the anxieties and fears. Number three is about the personality of the child. And number four are other factors, the environmental factors that can affect the child. So I'll go through one by one. The first factor is about the age and the stage of development. I teach in the university, and whenever I teach the students, the undergrads or the grad student, whenever they present a case, the first thing I would ask is, how old is this child? Because when you know how old is the child, you expect to know about the level of development of the child. Okay, as a pediatric dentist, you need to understand the level of development of the child. And child development is a continuum. It is a work in progress, and it may be uneven, but not a series of well-defined phases. Okay, and it differs from child to child. So a 4-year-old child A and a 4-year-old child B, while you know they should be about the same, there may be some differences. So this is to highlight with you, different stages in child 1 and child 2. And you need to, while you know the level of development, you also need to adjust your understanding for each child. You need to remember that children are not little people. I'm not sure whether you still remember this movie. This is an old photo I use. It's from the Lord of the Rings. And these are the hobbits in the foreground, the little people. Okay, children are not little people. So they are not adults. They are not little adults. We need to understand them as being children who are developing, and you need to know the different stages of their development. And this will influence their anxieties and behavior at the dentist office. So in child development, there are 5 things that you look out for. First is cognitive development. Second is language development. Third is perceptual development. And these 3 development really affects or really influence the child's intellectual and their understanding ability, how they understand things, how they become clever. And of course, there is a social development and motor development. So I'll go through one by one again. And we're still talking about children and their development. Okay. So first is cognitive development. What is cognitive development? It is the ability to acquire knowledge. It's your ability to understand things. And it changes radically from birth over time. Meaning, from birth, you don't know anything, to at 1 year old, you know something, to 3, 4, 5 years old, and you start going to school and you learn a lot more knowledge that you gain. So to talk about child development, we need to understand a simple theory that was described by Piaget. Okay, and you can read the paper like I listed in the previous slide. Okay, it's a very simple paper. You can get it on the internet. It talks about Piaget's theory. In stage 1, there's always the sensory motor period. And these are normally children between 0 to 2 years old. And they may be your patients. If you are a general dentist, maybe not. But if you're a pediatric dentist, you know you start seeing patients from age 1. So at the sensory motor period, the child learns mainly through their senses. They learn through taste, touch, sight, sound, and manipulation, all the senses. And the intelligence is related to the sensation, not the reflective thought. Babies don't think much. They, you give them a toy, they're happy with it, you take it away from them, they will cry. They do not think about what happens in between. I hope you can understand that. So they learn through taste, touch, sight, sound, and manipulation, things that make them happy. And you take it away, they may be upset with you. So, and then after that, they will go on to stage 2, which is called the pre-operational period. And these are children between the age of 2 to 7 years old. And this is where most of our patients group will belong to, okay, as a pediatric dentist. And even as a general dentist, if you become a general dentist, you see in your practice, children will come when they are normally within this age group. At this age group, children tend to believe what they see and hear. If you tell them, you're going to take out your teeth, you're going to see the dentist and take out the teeth, they're really going to believe, okay? And that's scary for them. And then during this period is also where they start speaking. And because they speak, there's language development. Even during this period, many children are egocentric. They think only about themselves. Okay, what makes them happy? I get the toy, I'm happy. I get to eat my chocolate, I'm happy. I get to eat my ice cream, I'm happy. You take it away from me, I'm not happy. They cannot see the other people's point of view. You take the chocolate away from them and tell them, hey, you're going to eat too many sweet things and you're going to get cavities. They don't understand that. I just still enjoy my chocolate. So they are egocentric. Their thinking is single-tracked and they can be inflexible. Stage 2, the pre-operational period of 2 to 7 years, the intelligence is based primarily on perception too. So how they look at things. And it's very important because how they look at you is also important. So I give you an example. If you see these 2 bottles of hand sanitizers, I think these are the most in thing now. Everybody is using a lot of hand sanitizers. The bottle on the left looks fat and short. The bottle on the right looks tall and thin, but they both contain 500 ml of hand sanitizers. You ask children, they may think that the short and fat one, the bigger looking one, contain more volume. So it's based on perception. So it's important to project a nice perception of yourself, to create a nice perception of yourself to the patient that come to see you. If you look angry and you look upset and you look fierce, they will perceive you as someone as a threat and they will be frightened of you. Then they develop stage 3, which is the concrete operational period from about 7 to 11 years old. And that's when children start going to school. That's when they start to think. And that's why, if in Singapore, primary 1, the junior school, we start at 7 years old. That's when children start to develop the ability to think based on logic and reasoning, okay? So they are able to consider another person's point of view. And if you have patients normally in the school-going age group, they tend to be cooperative at the dentist because you tell them, your tooth has a cavity, there's a hole, I need to fix it for you. Will you let me fix it? Most of the time they understand the logic and they will be able to allow you to do it. And by the time they reach stage 4, that's the formal operational period. This is for people who are in middle to high school. They are able to think abstractly and in propositions, and they can reach the highest level of intellectual development, and they become professors, and they become lawyers, and they become doctors. And they at this level, they should be able to understand most things, and they should be able to cooperate. But however, having said that, it's not reached by all individuals, especially those with developmental special needs, right? Developmental disorders. So cognitive development, how is it important for the dental team? We need to know that developmental stages are not so clear-cut, but there are guidelines, there are milestones, there are timelines, 0 to 2, 7 to 11, 11 to 15, okay? So there are developmental stages which are not so clear-cut, but there are guidelines for you to understand the level of thinking ability in your patients. So, but however, having said that, do not underestimate the thinking abilities of younger children, because some young children are very clever and they move on to the next stage very fast, as I mentioned to you. So children can be smarter than we think. But for the really young ones, I need you to think about, appealing to their senses, to their touch, to their sight, to their level of understanding to reduce the anxiety, not to communicate with them, not to say things like how we talk to another adult. So I use a lot of props, like the dental mirror and the model to show young children. Because if I tell them, I'm going to count your teeth, I'm going to check your teeth. What is checking? What is teeth? So to use a model like this with a mirror outside of their mouth is less threatening. And many young children will be able to understand that, oh, this is what the dentist is trying to do. Use the mirror to count teeth. And I let the child, we appeal to their sights, to their sound, to the sensation. So I let them touch my instruments. There's nothing wrong. Okay, of course, now with COVID pandemic, I don't think you want to let them touch the mirrors just like that. Maybe they should sanitize their hands or wash their hands first before they touch the mirrors. I hope you agree with that. Okay, but you can see that, children holding onto the mirrors, practicing with their own mouth would help them understand what you're going to do and reduce their anxiety. There's another picture of a child practicing with a mirror before I count his teeth. Next will be language development. Children also develop language, but to develop language, there must be appropriate stimulation. Okay, someone needs to be talking to them in a particular language. And if you think about it, language and thought are linked. You see, how you speak, how you understand, and how you think is in a particular language. Can you imagine thinking without a language? I think mostly in the English language. And I do think sometimes in the Malay language, that's my mother tongue. But I don't think in Bahasa Indonesia. So if you were to ask me to communicate in Bahasa Indonesia now, it's going to be difficult. So language handicap in a child who have a language handicap, it will be difficult for them to think about things, okay? And for you to communicate with them. So a child needs to have language abilities before you are able to communicate with them. And interestingly, this is a very nice table if you have to remember, children below 3 years old, their language development is limited. So therefore, behavior management by communication, all the techniques that you can describe, if it involves communicating in a language by speaking, any child below 3 years old is going to be quite poor. And from 3 years old onwards, it can be quite adequate and you can try. And from 4 years old, most children will be competent with language. They can actually understand most things you try to tell them. And therefore, behavior management by communication will be quite good. So what does it mean for the dental team? If you want to communicate, to use a language for the children, you need to use the same language as the child. You cannot be telling them, oh, I am going to use my handpiece. I'm going to put a burr into my handpiece and I'm going to prepare the tooth. It doesn't make sense to a child. Okay. So you're going to have to tell them that, hey, I have actually something to wash your teeth. It sprays water like your shower at home. And then I show them that there's water spraying into your hands and into your mouth. Okay. So that's using the same language as children. So the same language of children is an interesting word. It's called childrenese, just like Chinese or English, So the word language of children, I think this was described by Cook in his article way back in 1976, and it says childrenese. So let's practice some childrenese. What do you call the dental chair? So if you tell a patient that this is a dental chair, special chair, they may not be able to understand. So you may even want to call it a bed, something that lies flat, that they have to lie down on when you examine them. The spittoon, you cannot call it a spittoon, you can call it a sink, where you spit, you throw all the water into the sink. And the suction, I call it the straw, because it sucks all the water in the mouth. And the rubber dam, now I call it a mask, just like how people wear masks, right? Because of the COVID pandemic, the rubber dam is a nice mask. The caries excavator, I call it a spoon. The triple syringe, I call it a water spray. And the handpieces also, I call it a water spray. But the local anesthesia, I never call it injections, because if you call it injection, many children actually understand what injection means and they don't like it. So local anesthesia, I would say medicine that would put your cheeks to sleep, or medicine that makes your cheek feel fat. So I hope you can understand that you have to communicate in a language that children understands. So what can you do knowing about children's language development? Give simple instructions to children and be patient if the child doesn't understand, because they may not have the ability to understand. They are not trying to be difficult. And use words that can be understood and non-frightening. So use childrenese. And find out if after you try to communicate so much and the child still looks at you blankly or just are not able to follow the instructions, sometimes you may have to wonder if the child is developmentally special, with a developmental disorder like autism or such. Okay, along the way, you can see slides like this, which with a red heading, which is what can you do, and the yellow color words. I will later compile all these words into one document, and these are things that I think can be part of your action plan when you see patients. Third is perceptual development. Perceptual development is the information that is received by the senses that is analyzed and is made meaningful. So in older children, by 7 years old, they are able to determine information that are meaningful. Okay, they can understand, and that's why perceptual development has been formed by 7 years old. They go to school, they understand things better. Younger children have limited ability to give meaning to the information received. So what does it mean for the dental team? You have to let the child experience dental treatment gradually. Okay, you have to let them experience it in a nice, slow manner, building up from one simple experience to the other, not straight away jump into treatment, especially difficult ones. And do not let child have a negative perception of dentistry. It shouldn't be that a child comes to the dentist, the first time they see the dentist is to do something that is painful and scary. So what can you do to give a nice perception, how you present yourself, how you appear to the child? Okay, what can you do? Be friendly, right? A children's dentist must be friendly. If you're always going to be masam muka yang masam, yang tidak manis, it's not going to be nice for children. You must always be friendly, be kind, and then you should smile more. You want to see kids, you have to be smiling. The good thing now is sometimes you don't have to smile so much because we are all wearing masks. But you can say nice things. Children like praises. You must always puji anak-anak ini, right? You have to praise them. Say good things. Wow, today you are so handsome. You are so nice. Your hair is so nice. Your shoe is so nice. Your dress is so pretty. They will love it. The fourth development that we need to talk about is social development. And in social development, Bowlby's attachment theory is actually quite important to understand. Babies form specific attachment to their primary caregiver. And about 8 months old, infants show fear to strangers already. And separation anxiety, if you separate the child from their primary caregiver, this separation anxiety remains high until 5 years old. So I show you a picture. This is picture of kids who I can carry and hug them and, feel so good. That's the beautiful part about being a pediatric dentist, right? You can see children, they are so cute. You carry them. Then after that, you don't have to bring them home. You give them back to their parents. But what it means is that these kids, it's quite easy when they are below age 8 months old, right? For you to carry. And then after that, the next time you see them, maybe in 6 months, when they're closer to 1.5 years old, you try to do the same, they probably will not want you to carry them anymore because they will be anxious. They will have this separation anxiety from their primary caregiver. So what does it mean? Separation anxiety should be considered before insisting that young children must enter the clinic alone. When I was an undergraduate, we were treating patients. We were always taught to separate the mother from the child. We come in with the child into the operatory, the parents wait outside. But as a pediatric dentist now, and I've been a pediatric dentist since 1998, I always insist that parents come in because I find that having separation, the child is often always already afraid coming to a new environment at the dental office. Why make it more difficult for them? So let's have the parents and the child together, okay? So this is a severe case of separation anxiety, and this mother and this child is so clingy to each other, and in fact, this This is a child leaving my office rather than coming towards me. So what can you do if you see young children and you suspect they may be anxious? You can always advise a familiarization tour. You can advise a familiarization tour, especially if your office is near where they live. The child can come in and have a look around first. Um, the other thing is to train your staff, especially the reception staff, to note if the child is extra clingy. In a big waiting area like mine, I expect children to come in and be comfortable and sitting down and playing. But if the child is already clingy to the parents, I know there will be a problem later on to separate the child from the parent to sit on the dental chair. Okay. And if you need to separate the child from the parent, do it slowly. Not straight away come in, okay, child sits on the dental chair, parents sit outside, or parents sit at one side. That creates a lot of anxiety in the children and it will not help you. So this is what I always do in my office. A child comes in, they don't straight away jump onto the chair. They sit next to the parents. We have a chat. That's how we take the history, right? The dental history. We have a chat, get the child to warm up and be comfortable before they sit on the chair. The last development is motor development. They tend to be a bit more predictable and it changes, and it's normally completed by infancy. By 1-2 years old it's completed, and the changes that follow are just refinements like walking and all. This does not quite affect the way we manage our children, but just that we need to understand, in seeing young children, you cannot expect them to be doing things on their own. Like, you may have to carry some young children onto the dental chair because they cannot climb onto the dental chair. They don't have enough motor development yet. So I hope I've not been speaking too fast and you have been able to follow me. I'm still talking about the child now. We still need to understand about the child. The first was about the stage of child development. The second thing that we need to understand about our child patient is about their anxieties and fears. Children can have fears or anxieties that are acquired. That means they get it from somewhere. So where do children get it from? From a previous bad experience, from a dentist who wasn't careful with a child and did something that frightened the child and give a negative perception of the dentist, unfortunately, right? Children can also get fears from siblings or parents, because many parents are actually scared of the dentist and they will tell the kids funny things. You go to the dentist or you don't brush the teeth, they will take out your teeth. You don't brush your teeth, they will drill your teeth. That is very scary. And of course, from experience of using local anesthesia or even vaccination, right? Children who have had vaccination, I do not like children to see me like a few days after they've seen a pediatrician for their vaccination, because the pain, they will associate me with their pediatrician, and that acquired anxiety will be expressed at the dentist as well. Meaning they come, they expect you to give the needle as well, and they get very scared. But young children have protective fears. It's a natural fear. Protective fears of young children is natural. Okay? It is the fear of the unknown. They see, oh, this is somebody I don't recognize. This is a place that I am not familiar with. They will be afraid. And that's good, because if your child is not afraid of strangers and of the unknown, they will get into trouble, right? Children have a fear of pain and of bodily harm. And children, remember just now we talked about social development, have separation anxieties. So protective fears of young children is natural. It prevents children from getting into trouble, right? If they are not afraid, they will do funny things that they will get into danger. It is especially high in children who are from about age 2 years old. And at 3 years old, they are still having these protective fears. But by 4 years old, so that's again the magic age. If you remember language development just now, and now protective fears of young children, by 4 years old, we expect language development to be good. We expect protective fears or natural fears in young children also to be minimal already. So if I were to ask you to examine a 2-year-old child like Nicole in this picture, right, to examine him and to be able to see his teeth like this, how would you be able to do it? Do you think you can tell Nicole, hello Nicole, I'm Dr. Rashid, I'm going to use a mirror, I'm going to count your teeth and check how many teeth you have? I don't think that would work, right? Because developmentally, she's in stage 1 or sensory motor period, where she will learn only from her senses. We know at age 2 years old, language development is often inadequate and the natural fears are high. If you were to try to do that and get the child to sit on the chair and to examine the teeth, you will never be able to do it. So that's why there's always the knee-to-knee method. I always apply the knee-to-knee method from a child who is 3 years old and below. I will do the explanation to the mother. I will do the explanation to the father. I will still try to do the explanation to the child, but expecting the child not to be able to understand fully. Okay? So I will not then persuade the child to open his mouth. I will go knee-to-knee method. Mommy will hold. We have a quick look, and that's how we do in very young children. That's application of your knowledge of your child development. I hope you can understand that. So anxieties and fears may intensify or misattribute pain. It may make pain even more painful. That's basically what it's saying. You need to understand that majority of children that come to the clinic are anxious. And in fact, even the parents are anxious. Okay. And anxiety can increase from horror stories. And some children are fearful, usually, especially those with previous unpleasant experience. Okay. Especially people who have been telling them all the nasty, nasty stories. So what can you do to reduce the fear? You should gain the child's confidence and trust. Okay, always you need to gain the child's confidence. So don't hurt them. Don't make it even more scary. Be friendly. I think I've said this twice already. And keep emphasizing the positives. Always say the good things. Okay, always say the good things. I'm just going to count your teeth. I'm just going to brush your teeth. I'm going to have a look at your teeth. Okay, not that I'm going to take out your teeth. I'm going to drill your teeth. I'm going to fix your teeth. No. Okay, so still in understanding the child, other than the development, other than anxieties and fears, we also need to understand that different children have different personalities. Okay, and their personalities can be classified into 3 types according to Thomas and Chess. You know, this is an old paper, but I think children personalities don't change much. Children can be easy temperament, easy personality. They are always positive. You tell them something, they are positive. They're okay. Can you sit on the chair? Okay. Can you open your mouth? Okay. Or they can be difficult. There's a tendency to withdraw. They cling to their parents. Okay. They cannot adapt to the new environment. They do not want to lie down because it's, I don't want to sit on the chair. It moves me back. Okay. Or they can be slow to warm up, meaning they are just shy. They have low intensity reaction to problems. They don't quite scream, but they will do it, but it will take time. Obviously, this little boy has an easy temperament, right? I can do local anesthesia. I can put rubber dam. Then after that, he needed to go to the washroom. He can still go out to the toilet and come back. So that's easy. But some children are not so easy, right? So what does it mean? You need to understand children's temperament, okay? That there are these 3 classes of children. So, and their personality will predict how they behave at the dentist. The difficult one, you need to structure your treatment plan to get through to them. So you need to make the difficult one becomes easy. So it's not overnight, it's not on the spot, it will take time. So your treatment plan have to be structured from the simplest to the most difficult. The slow to warm up type, you just need them to come in a little bit earlier for them to adjust to the new environment. So you need to recognize the different characters in children. Then there are other factors that affect children's behavior, right? For example, their surroundings, right? The environment. The child may be chronically ill and has been seeing a pediatrician or an oncologist or a hematologist every week, every month to get treatment. They will definitely be anxious at the dentist. And then family issues like divorced parents, new siblings, they are jealous of the younger one. They think the parents are putting too much attention to the younger ones, and they come to the dentist. They think it's just like, you don't care about me. So it causes a lot of anxiety, or if they have lost someone. Also, the socioeconomic status of the child. They may lack social skills or neglected children, okay, because they can be attention seeking. They may be the little thing that you do, the little touch of their teeth, they may scream because they just want attention. And children who have had non-accidental injuries, like abused children, may have real, genuine fears. So, so these are important information about your child, about your child patient, that you need to know to understand why they behave when they come to your dental office or dental practice. So how do you assess these children for potential cooperation? There are two ways. Number one is from the history, right? So when you take history, you ask certain things. You ask about the age. Age tells you the level of development, okay, the child development. The medical history can tell you about acquired fears, especially if they have been seeing the pediatrician or they've just been hospitalized. Another bad time to see a patient in the dental office is after they have been hospitalized for something, a simple fever, high fever. If the child has been hospitalized for the last 1 week and they've been having intravenous drips, they will be afraid of the dentist. Social history will also tell you, okay, whether they have any insecurities, like how many kids are there in the family, is he the youngest or he is the middle child, right? Not getting so much attention. The school tells you also the level of development, because some parents will not tell you the child has some developmental disorders, right? They may tell you everything is normal, but they actually attend a special school. Okay, a child in special school obviously may have some intellectual developmental disorders, right? And school also can tell you about separation, how you go to school, how are they dropped off easily at school, or does he always still cry at school? I have a patient who's 6 years old and still cannot attend school properly because every day she will cry. Okay, and who is the primary carer and how easy is it to separate? Because sometimes the primary carer is not the mother, it can be the helper or the nanny, right? And you may want the nanny to come at the dental visit rather than just having the parents. And from the dental history, what experience have they had, at the dentist, and whether how difficult it was. If the child comes in and very anxious and you ask, oh, the last visit, for the first time he came to see the dentist, he had to have an injection and took a loose or wobbly tooth out, you can understand why there is some anxiety. You can also assess the child's potential cooperation by observation, right? How they enter the clinic, how they play, that you can see their personality, how they play, how they relate to the parents, and how they separate from the parents when they are in your waiting area, okay? And from your response to conversation, whether they are willing to answer to you, whether they are shy, and then they take a long time before they reply to you, those are probably the slow to warm up. And then the level of language development, because you can be speaking to a child who's 4 years old and you should be able to have some level of understanding and still not be able to understand. That would tell you the level of development and how well you can communicate with them. So from there, you can have a Frankel behavior rating scale. And I'm sure many of you would have been taught in your undergraduate program, and of course the postgrad, we still use Frankel's rating scale way back in 1962, right? Rating number 1 is definitely negative. The two negatives, minus, minus. The rating 2 is negative. Rating 3 is positive, and rating 4 is definitely positive, right? So definitely negative are those children who come in and they have forceful crying, they are fearful, and everything is negative. You try to show them things, they will not open to ideas of, doing things, anything on them. And then the single negative are the uncooperative child, but there is some evidence of the negative attitude, but you can still try to engage them. And at some instances, they may still be able to follow what you want them to do. And then the positive ones, they are happy to do, but they are cautious, they are willing to comply, and they follow directions cooperatively, but still a little bit unsure. And the definitely positive are the kids that you can have a good rapport, you can have a good laugh, you talk to them, they will follow your instructions, and then you can do anything and everything in their mouth. All right. So I've mentioned about how we need to understand the child patients. And from the understanding our child patient, we have actually basically a diagnosis. The Frankel rating scale is actually a diagnosis of the child's behavior. If you talk about as a dentist, as a doctor, you have diagnosis for conditions. For example, you see cavities, the diagnosis is dental caries, right? So in seeing a child, in assessing a child, you need to have a diagnosis for his potential behavior. And that's I use the Frankel rating scale. Okay, next, I'm going to talk to you about the parents. Let me see how good are we with time. Okay, the parents, there's always anxieties, okay? Parents also influence the child's behavior. Parents influence the child's behavior. How? By having their own anxieties, by the parents' attitude, and by the parents' parenting practices. Okay, so first let's go with the parents' anxiety. Parental anxiety must be well managed. There's a hypertrophy. There's a lot of parental anxiety regarding the welfare of children under the custody of dentists and other healthcare providers. That's said by Pinkham in 1995. Okay, parents are always afraid that they come to the dentist will hurt their children. I don't understand this sometimes. They know that the child has a dental issue, an oral health issue. They come to see the professional and they think that the dentists are going to hurt them. But you can't blame them too, because sometimes we do procedures which is not comfortable. Okay, so that's why we need to manage the child well. We need to manage the parents well too. Children may acquire the anxieties of people around them. Children read the environment very well. If my mother is scared, I will feel scared. That's how children behave. Okay, maternal or parental anxiety may influence the child's behavior. So if we know that, should the parents be allowed to stay? Yes, if they are able to support the child positively. No, if they are unable or unwilling to provide the appropriate support. But you cannot tell parents to get out and leave the room and deny that access, because I think especially so now, where it's very difficult to practice, where you can get into trouble with the legal issues. You do not want to be accused of hurting a child when the parents are not there, because they can accuse you of assault, battery to the child. Since they are not there, it's going to be making things worse. Okay, and knowing about how children behave when they are being separated from the parents, I always prefer if the parents are there. Okay. So parental anxiety, if you have the parents in the room, it helps reduce the child's anxiety with emotional support, because my mother is there. The child should feel secure, should be able to cooperate better. Okay. And with the parents in the surgery, it helps reinforce the positive behavior, because when you tell the child, oh, you're doing very well, the mother will definitely say, oh, you're doing so well. They even praise them even more. That helps reinforce the positive behavior. And if you need to hold the child, it's best to ask the parents to hold the child rather than you hold the child and hurt the child and get into trouble with complaints. It prevents tension between the parents and dentists, because they know what you're doing exactly. They are there to witness what you do and that you are not hurting the child. But sometimes, yes, I do agree that parents may have to leave, especially if they distract the child with silly instructions, by making the child afraid, by alarming the child with words like pain and injection, by talking to the child all the time until they do not follow the dentist instruction, and if you cannot even use voice control with them. But having said that, as a practicing pediatric dentist now, I have parents in the operating room, in the surgery all the time with me. It prevents further problems, in my opinion. Okay, so what can you do? If you know the parents is anxious, rather than send them out, there are ways to manage parents. And that's one thing I learned as you go along. When we were in dental school, you are taught about child behavior management. Nobody teach us about parental behavior management. But as a practicing dentist, you realize that you learn to manage the parents, and that's important to be able to manage children. Okay, so what can you do? You need to ease the parents' anxiety. You need to show that, hey, there's nothing to worry. We have your child's interest in our hearts. We want to make him feel happy. We want to make him feel good. We want to make him have a good, healthy mouth. Okay, so you don't have to worry. We're not going to hurt him. Get parents to work together with you. So when you assure them of that, you need to get the parents to work with you. Hey, we need to do this, because otherwise your child is going to have bigger issues with his teeth, bigger issues in his mouth. We have to work together to get him to cooperate. Okay, and you have to prepare the parents before the appointment sometimes. That's where you need to train your front desk When they take the calls, some parents will tell them, hey, I'm actually scared to bring my child to see the dentist, right? So you can tell the parents, don't worry, we're going to take good care of them. But please don't tell your child the difficult things about coming to the dentist. Don't use the words like injections. Don't use the words about taking out teeth. No. So leave it to the dental team to explain the procedure. And preparing the parents in advance has been proven effective, okay, in promoting good behavior in children when they come to the dental office. I'm still on the topic of parents. We also have to talk about parental attitude, okay? Parents can be positive towards dentists. Parents can be supportive to the dentist and the child. But you and I need to understand that there are some parents who are negative and question the importance of treatment. And sometimes you wonder why they actually bring these children to the dentist, okay? I guess in private practice where parents come and make an appointment and be prepared to pay fees for the treatment, I seldom get this kind of parents. But I guess if you are working in a hospital and the patients are referred from other specialists, other pediatricians, other dentists, maybe you can get parents who are a bit negative in their behavior. And it's important for us to educate them then. Okay, to overcome this, you have to educate them on the importance of the dental health and oral health. Okay. So in parents also, there's parenting practices. There are basically 4 types of parenting practices. They can be overprotective, they can be over-indulgent, they can be over-authoritative, and they can be under-affectionate. Okay, the overprotective parents, they want to protect their child all the time. They insist on accompanying the child. Sometimes they can be overbearing and transmit their fear. The child then becomes shy and fearful, and they lack confidence because everything is done for them by their parents. This can be a challenge too, because if the parents are overprotective, it is going to be a challenge for the dentist to provide the treatment, because they will think that you may be wanting to do difficult things to their child, and they may make the situation difficult for the child and make them even more fearful. The overindulgent parents, they basically, you cannot call them that, but they basically spoil the kids, right? You cannot say spoil, right, in front of the parents, but you and I know what it means, right? They overindulge, they give in to the child everything. The problem with this type of parents is that the child will manipulate their parents. If they don't want to do the treatment, they will tell the parents they don't want to do the treatment, and that's that. And the parents normally give in to the child. And that's when it's going to be difficult providing the treatment through behavior management. Then there are over-authoritative parents, the dominating parents, right? They just tell you what to do. Sit down there, just listen to the dentist. While you think this may be helpful, sometimes it may be helpful, sometimes it is not, because very often the child will be actually fighting with the parents. They are having their own private wars. I don't want to do this because you tell me to do this, mommy. Okay? They are having their own private wars, and then you are caught in between. And the under-affectionate or rejecting parents, the parents who do not care so much, there may be some social economic issues sometimes, right? Child may have a poor self-image, non-responsive, but very often I don't think this is common. So what can you do? Always advise the parents to let the dentist do the job. Communicate your treatment plan and objectives clearly with the parents, because when they see that you know what you're doing, you're not going to hurt the child, you are involving them in the treatment, and you get them to work together, very often you can manage the child and the parents to get them to cooperate to do the dental treatment. Okay, the dental team can also affect the children's behavior. How? Through our personality and our attitude, okay? The dental team's personality, you must always be warm and friendly, you must be truthful and trustworthy, you must be tolerant, and you must be flexible, okay? We must be positive to our patients. And in your positive attitude, you need to communicate it. You need to let the child know that you are positive towards them. How? Through verbal communication, by talking to the child. Don't just talk to the parents. The child is your patient. You need to talk and communicate with your patients. You need to engage them. You need to coach them. Okay, this is what you do. When I wash your teeth, you need to open your mouth. And then when we put the straw in, you need to let us suck the saliva out. And if he does it well, oh, you're a very clever boy, you're a good boy. Say good things to the child. Non-verbal communication is also important. Remember to smile, remember to have eye contact. And children like to be petted. You can pat their shoulder, you can pat their head and say good boy. Never be fierce, never scold patients, never put them down, and never lose your cool. Okay? There are other factors that can also affect children's behavior, like the appointment, the time of day. When they are tired is never a good time. Okay? Don't make children wait for you too long. And treatment duration should be short. Children's attention span is short. If you want a child to cooperate at the dentist, you shouldn't be doing treatment that lasts 1.5 hours. Nobody can sit through that long. Okay? And the environment that you create must be child-friendly and must be child-safe. So this is a picture of my waiting area. You need to show that you are really keen on seeing children by putting out the books, the toys, the things that the children can occupy themselves with and make them happy in the waiting area before coming to see you. Can you imagine if your child patient outside in the waiting area is already unhappy and they come into your office? Do you think they're going to cooperate, right? So put some decorations in the waiting area and the operatory. In my operatory, actually, is empty. I don't put decorations in my operatory, but it's mostly in the waiting area. The appointment time, not when they are tired, not at their nap time, not when it's too long. Make the waiting time short, and you need to work efficiently and to prepare the instruments appropriately. Okay, so make them happy while they are waiting for you. By the time they come into your office, they are ready to behave and cooperate. So this is the first part of my lecture. I've gone on for quite a while. I'm not sure whether you have any questions. If you don't have, then maybe I can just continue.
Maybe you can just continue. We have, until now, we have 5 questions actually, Dr. Rashid Tahir.
Whoa, am I speaking too fast?
I don't think so. We can catch your message.
Okay, cool.
You can proceed with the second part if you want to.
All right, so I'll do the second part, then we take all the questions together. Is that all right?
Yes.
Okay.
Great. Thank you.
Thank you. Okay, so for the next part, it's just about the behavior management that I've listed just now. So this is the easiest part. I think many of you would probably have been taught that, I hope, right? But basically, behavior management is actually cooperation between the dental team and the child patient. Both parties need to cooperate. When we say children are not cooperative, we are just blaming it on one person, okay? So it is cooperation between two parties. So cooperation is between two or more individuals taking effective action together because of the communication that they have. I, as a dentist, ask a child, okay, that, hey, please, little girl, please, little boy, can you please sit down and open your mouth and let me clean your teeth and put some fillings in, okay? So the child must understand that, oh, this man is telling me I need to open my mouth, let him clean it, even though it feels weird, okay? And then put something in my mouth so that my tooth will be good again. And I must be happy to do that. So that's the cooperation that is going on. And there must be communication, okay? The problem with behavior management is dentistry for children is complex because the communication is between the dental team and the child. Between the dentist, like me, who is a grown man, right? Who is 50 years old, talking to a 4-year-old or a 2-year-old or a 3-year-old child, right? So it's a complex communication. I'm not talking to another person who is of my same age and of the same level of development and intellect as me. So interruption of this communication will result in failure to perform a procedure, right? So for example, you do, and the child starts screaming, ah, is there any more communication? You tell him, please don't cry, but he's still screaming, ah, can he listen to you? Can he follow your instructions? No. So is there any more communication? There's no communication. When there's no communication, will there be cooperation? There won't be any. So when you see that as a dentist who's trained, you must have skills that intercept and stop such behaviors. So communication can continue, right? So what do? You may have to stop the procedure, get the child to rinse his mouth, maybe to calm down, to stop the crying for a while so that the communication process can go on, and then you can start doing the procedure again. So behavior management is the means by which the dental health team effectively and efficiently performs a treatment for a child. Okay, so it must be effective and it must be efficient. It mustn't take too long. It must be, and you must complete the treatment for the child. And then not only that, to have good behavior management, it must instill a positive dental attitude, meaning not just finish the treatment, you must be able to make the child accept the same treatment at another visit. Okay. If you don't do that, that means your behavior management has failed. You have just created a negative perception of dentistry for the child. So the dental team's attitude must be positive, right? You must be happy to treat children. You must be confident that you are able to perform the treatment. You must be motivated because you think of the child's well-being. Okay, I'm doing this not just because of the financial motivation, but you are healing the child, right, from his oral health and oral diseases. And you must be prepared because you must have the necessary knowledge and skill, like what you are trying to acquire now by learning behavior management for children, right? So behavior management can be pharmacologic and non-pharmacologic. Pharmacologic is when you start using sedation techniques, when you use drugs to get the child to cooperate. And that's beyond the scope of today's lecture. And if you want that, we can always do it another time. So the spectrum of patient management, and this is very important. I like this graph. This graph was in a chapter in the book edited by Richard Welbury. It's into its 4th edition now. I started with the 1st edition. And this chapter was written by my boss and my professor at the Eastman, Professor Graham Roberts. And it shows that for most children, the highest frequency you can do is behavior management. You should be able to do most of your pediatric dentistry work by doing behavior management. Okay. In some children, you will need local anesthesia. In a small minority, you will need sedation. And an even small minority, you will need general anesthesia. And that's true. I did an audit of my patients a long time ago, right? Children needing general anesthesia forms only 5% of my patient pool. And those requiring sedation, probably about 10%. So about 90% of the kids are done with behavior management with or without local anesthesia. And I think that's what pediatric dentists should be good at. So we've talked about anxious children, right? And you need to understand about their development and how and what makes them affects their anxiety. So from there, you can diagnose their behavior or come to a behavior rating scale using the Frankel behavior scale. Then you can have you plan your behavior management strategy before you can get successful treatment in the kids. The only problem with doing dentistry for children sometimes is you need to recognize that for no pain dentistry, you need to have some pain, and that's giving the needle. And this shows you a young child, right? He is below 4. I think this child, when he saw me, he was about 3+, right? And that's why he's still sitting with his parents. Remember, I don't separate them when they are so young. Having local anesthesia. And I like this machine. I don't know whether you know about this machine. I still use this machine. It's been 14 years I've been using this machine. It's called the wand, okay? It's a local anesthetic machine. It's a computerized system. I still think it is equally painful giving the wand injection. It's just that it's done slowly. And the other thing I like about the wand is that it doesn't look like any traditional injection, right? So you can actually deceive with some deception for the patient. So non-pharmacologic behavior management allows behavior shaping. That means you shape the behavior of the child so that they can cooperate for treatment, not only one time, but at subsequent visits, so that you always get positive and compliant behavior that is always good for the dentist. For you to do that, you need awareness of the practical methods of managing behavior. So you need to know the psychological principles that we have gone through just now and issues of growth and development. Okay, so there goes the behavior techniques that I listed in the beginning. So we'll go through one by one. The most commonly used one is tell, show, do. Okay, why tell and show? Because it addresses the anxiety of the unknown. It is in telling and showing, you depend on the child's You want to relieve the child of his natural anxieties, remember? Unknown. Natural protective fears of children is of the unknown, right? So you want to reduce the anxiety by them understanding the procedure. So for them to understand procedure, you need to communicate clearly. So they need to have sufficient level of cognitive development, right? You need to have language development, right? And the perceptual development as well. You need to show them so that they do not perceive the instruments that you use as a threat. So all this development that I talked to you about in the last 45 minutes is relevant to what we do. But when telling and showing, please remember tell, show, tell, show, tell, show, but must do. Okay? So don't forget to do. Ultimately, you still need to do the treatment. The other method is actually modeling. Is when a child observes another child, either by using a video or live modeling, the child watching the model behave well because they learn from the model. And the model actually behave even better because they know that someone is watching them and they feel proud that, hey, actually there's this girl or this boy who's watching me and I need to be very good for them. So this is a beautiful picture, I think, right? The siblings, they are there. They're both not afraid, right? But modeling is to get a child to watch a child having treatment and is cooperative. The third method is distraction. Distraction keep the child's mind off the anxieties. So how do you distract children? By talking, by telling and showing. That's what tell, show, do does, you see? By using audio tapes, by using videotapes, by using guided fantasy, right? By telling them, oh, by we're gonna put this medicine into your mouth, right? I'm gonna put some cream on your cheeks, and then after that, it's gonna feel strange. And there are little fairies that are going into your cheeks, and they're gonna tickle your cheeks, and then your cheeks is gonna be feeling fat. It's when you're doing your local anesthesia, for example. Okay, so you distract them by telling them all the nice stories. Contingent distraction is when they are good, they get the distractor, but when they are bad behavior, we remove the distractor. For example, a child wanting to use the iPad, right, to watch a TV, to watch a movie. And if they don't behave, you switch it off or you take it away from them. Then when they behave again, you give it again. So that's contingent distraction. Okay. So in my office, I have a distractor. It's up on the ceiling. I use videos. I use movies, right? And if the child doesn't behave, we switch it off. We take away. And if you are behaving again, we put it back on. Systematic desensitization is to reduce anxiety by first presenting a situation that evokes little fear. So you build up simple to the most difficult treatment. Okay, so you progressively introduce stimuli that are more fear-provoking. Okay, again, you do tell, show, do, right? It's also desensitization because you tell, you show, right? Simple, right? Then you do. So this is telling, showing, right? Telling and showing, and then they do on themselves, and then finally you get to do on in their mouth for the kids, right? So this I think is quite a good example of systematic desensitization, right? Giving the local anesthesia. If you look at me giving the LA, it is the same hand positions. So I tell the child first, oh, I show you this cotton bud. I'm going to put some toothpaste on it. I'm going to rub the toothpaste onto your gums. So I do that, right? And then after that, they can't see my wand, right? They don't suspect it's actually an injection, a syringe. So I come in from the same position. I say, okay, now I'm going to move my fingers a little bit next to your cheeks. You're going to feel it moving, and then you're going to feel your cheeks feeling fat. Okay, so that's slowly doing something from easy to the most difficult. Positive reinforcement is when you give a reward for a good behavior. Remember, it's a reward. So what's a reward? They do good behavior, they get the reward, not a bribe. What's a bribe? A bribe means, oh, I give you this, okay? I give you a toy, but you need to be good. That's bribing. But you be good, okay? After you are good, then I give you a reward. There's a difference. Okay, a praise or a pat on the back or stickers or toys, they are rewards, and children look forward to it. So in my office, I have a treasure chest full of toys. At the end of treatment, they get a reward, and children actually look forward to it. Contingent escape is escape from treatment, is a powerful motivation, right? Allowing the child to stop treatment on an agreed signal gives sense of control and decrease anxiety. So when the child is able to escape from the treatment, it motivates them. Okay. So example, if you put your hands up, many dentists will tell them, okay, if you put your hands up, I will stop. Okay. But if the clever child, they will do time delaying tactics. What does it mean? When you do a little bit, they already put their hands up, and you do a bit more, they put their hands up. You will never finish. So rather than the child deciding when is the escape time, I am the one, the dentist, deciding the escape time from the child. So, for example, when I'm doing a cavity preparation, I will tell them when I use the handpiece, I will count to 3. So 1, 2, 3, then I will stop. That's the escape, not the child putting up the hand to escape. I hope you understand that. Okay, voice control. I hardly use voice control anymore now because it is an aversive technique. Okay. Having said that, it helps quickly regain control of the cooperative behavior. For example, a child who's screaming, then he's not going to listen to you. Sometimes by raising your voice a little bit, I say, hey, quiet, please, don't shout. That's voice control. You can regain control of the communication again. Okay, loud commands reduce disruptive behavior. But I find that it's a little bit difficult nowadays because parents, over the years, the way parents behave are also different. They do not allow or they do not like people to raise their voice to their children. So if you want to use voice control, you have to understand or you need to get permission from the parents first. Okay. So meaning before you start treatment, you're going to say that, hey, I think I foresee your child may not be so cooperative. Let's say if he shouts, I am going to raise my voice a little bit. Is that okay with you? Okay. So please always check with the parents. I do not do physical restraints, right? So there's a clause there. I do not use purpose boards in my practice. Physical restraints by having purpose board, pedi wrap, or having the parents and dental assistant is one way of managing behavior. I don't use it, okay? But there are some instances where you may need to, and I won't judge you for that. For example, you work where there is no access to operating rooms, and you have to do a child who has an acute infection, and you have to extract a tooth. What are you going to do with? So you may have to do restraint. Another example is when you're seeing special needs kids and you want to avoid the general anesthetic, you may need to consider physical restraint. Okay. So, but if you use physical restraint, you need to know that the objective is for behavior control and not punishment. Not because, oh, you're not cooperative. Nakal betul anak ini, ya. Mari kita rap. No, it's not, you're not supposed to do that. Okay. It's to protect the child so that they don't struggle and injure themselves. But please remember that you need parental consent. So I like, rather than physical restraint, I like the word clinical holding, right? It's the use of physical holds, right? In clinical holding. So a parent can hold a child to assist or support a patient to receive clinical dental care or treatment in situations where their behavior may limit the ability of the dental team to effectively deliver treatment, or where the patient's behavior may present a safety risk to themselves, members of the dental team, or other accompanying person. So when they hold, so it's clinical holding. I think it sounds so much nicer. And this is from the British Society for the Disabled. Okay, so this is a photo of a child. This child has autism. He is capable of communicating a little bit, right, and can understand. So I actually get him to sit on the chair, and his legs is over the mom's lap, and the mommy is actually holding his hands. Okay, so this is another way, right? Some form of clinical holding, right? So the mommy is actually seated there and holding the child's hands. In special needs cases, I don't normally wrap. If they need, some parents will hold their hands, right? But I also like treating children, especially who are on the wheelchair or on the push chairs, because they normally have their own restraining system. So you don't have to have additional holding for these patients. Okay, I think that's about everything that I have to speak about behavior management, and I hope you enjoyed this comic strip. He's gone to the dentist and say thank you. The dentist said I was a good patient and gave me a free toothbrush, and I was hoping for a dog or a bicycle. Okay, a reward for being good. Thank you.
It's a very big hope.
just before I go, there's another slide that I need to show. This is the action plan. I'm not sure whether it will launch. Yeah, it does. So if you see this just now, along the way, I told you about certain slides, right? That what you can do when you see patients, other than knowing the 8 behavior management techniques, correct? The 8 behavior management techniques that I mentioned. What else can you do along the way? You can give simple instructions. You can be patient if the child doesn't understand, so all this. But if I were to break it down to the next page, I think it makes more sense for you to use it as an action plan for you before you see the patient, and together with your knowledge of behavior management to be able to manage your patients better. See, before the visit, you can advise a familiarization tour. You can ease the parents' anxiety. You can get parents to work together with the dental team. You can prepare the parents before the appointment by telling them not to use negative words. Leave it to the dental team to explain the procedure. Advise the parents to let the dentist do the job. Then your decorations in the waiting area so that the child doesn't get bored, right? And in the operatory, you have some distractors for them. Your appointment not too long, not too short, not when the child is tired. And during the dental visit, what can you do? You can give simple instructions, be patient if the child doesn't understand, use words that they can understand, like childrenese. And if you try to communicate and you expect the child to have sufficient cognitive abilities and they don't, you may need to investigate further whether the child has learning difficulties or developmental disorders, and if they are special. Be friendly, be kind, smile, lots of praises. Take note if the child is extra clingy. Separate the child from the parents slowly. Gain the child's confidence and trust. Be friendly again. Always be friendly. Keep emphasizing the positives. Recognize different characters in children. Diagnose the child behavior to work out the management strategy. Communicate your treatment plan and objectives clearly. Get parents to work together. And your procedure, you need to work efficiently in doing four-handed dentistry. That's how you can manage your children better. Thank you very much.
Thank you very much, Dr. Rashid Tahir, for the very excellent presentation. Actually, we do have thought about that we have to put our main attention to the age and developmental stage. But when we do meet the patient, and all of that theory is blown away. So thank you very much
Yeah,
that
that's
you
not.
already underlined it for us and re-mention and remember it for us. It is very, very nice presentation, Dr. Rashid Tahir.
Thank you.
So we will continue to the question and answer session.
Sure.
Oh, so from the chat room, oh, okay. We have questions from Michael Raharja. So he is a third-year student on Faculty of Dental Medicine.
Right.
Dr. Rashid, I would like to ask, in this pandemic era, we have to prioritize safety first in our treatment. Let's say we have to wear level 3 hazmat suit and set aside the toys and decoration that are not necessary in our dental clinic. The question is, what approach would you use in terms of treating uncooperative children patient, whereas some children might get frightened as soon as they see the unfamiliar atmosphere in our dental clinic, like our PPE and no toys. This is the first question, Dr. Rashid Tahir.
Very, very good question from an undergrad, huh?
Yes.
Yeah. It's
Great.
interesting because you see, I'm gonna try and see whether I can raise my computer a bit. You will see my waiting area. It's not as nice as it used to
Ah,
because
thank
you
you.
see everything is taped up. So,
Okay.
so while we have a nice waiting area where the kids used to come and play, there is nothing to do now. I mean, they come in, they are seated in areas. So I have one waiting area here. Can you see the marking on the floor? I'm not sure whether you can see the marking on the floor. So that is one area. I
Yes.
have another area that's called area D. I'm not sure whether you can see area
Yes.
D.
Yes. We
So
can
we
see it.
divide the waiting area into specific areas for specific families. So they do not
Gathered.
other. So I agree. The children now, we don't even allow them to play. I used to have PlayStation. I have a table, a football table outside. They look forward to coming, but they can't. Having said, and then when they come into the room, they see me all masked up, right? But at least the good thing is I don't wear hazmat suits like you guys.
Ah.
But the good thing is I think children are fast learners. They
Okay.
know now there's a pandemic. In Singapore, all kids from 2 years old and above are required to wear masks or at least a face shield. And they go to school, they wear masks or they wear face shield. So they are familiar with people looking like spacemen in a way, right? So in terms of perception wise, I am hoping that it will be the same in Indonesia, that the kids now that there's a pandemic, know that there's a pandemic going, and they actually recognize that people now dress differently, at least with a mask. Okay, so perception wise, I think that should be better already as the pandemic goes on. People are more aware, people know. The other thing you can do is to take a picture of yourself with and without the suit.
So they can compare.
Yeah, so that you can show the patient that, hey, I am this. And then, you can always do, you guys are good at social media and all. I don't know, maybe use what, TikTok or whatever, right? To put on your suit and come in and out of it very quickly to show that you are the same person. And that is fun. Try to make it fun. But in terms of treatment, it is going to be difficult because what happens was during our lockdown in Singapore, we were only allowed to see emergency patients. And to see emergency patients mean that we cannot be doing acclimatization procedures, right? In managing children, one of the things that you want to do is always acclimatization, getting to do simple treatment going to the most difficult. So emergency means take out the tooth or antibiotics. So I would suggest that if the case is not uh, urgent, you buy time with it. Meaning, then that's going to be talking about treatment that can buy time, like medications, antibiotics, fluorides, silver diamine fluoride, to buy time for the child. Um, the other option, of course, is to use pharmacologic methods. But again, pharmacologic methods creates challenges because it is often our work is aerosol generating procedures, right? So only in certain hospitals that can accommodate that. It's not an easy question to answer. I guess you have to try your best, right? You will have to try your best to um, solve the problem in terms of the emergency, in terms of managing the immediate treatment that is required, and then to buy time so that the patient can be trained for better or shaped with their behavior management in the future.
Maybe we have to make a like pre-appointment and then by phone maybe to explain that we have some limitation during this pandemic.
Correct.
Eh,
So there is, I think, the use of technology, using consultation via teleconsult is becoming popular. Uh, but teleconsult in dentistry has limited applications because you can probably help diagnose the problem. You can probably advise on medications to use. But dentistry is a surgical discipline. You need to do the treatment. And that's where it's going to be always challenging.
Yes, thank you. Maybe I hope who is the Michael Harja, is it okay? because we have lots of questions are waiting. So the second question is from Janice. She is also the third year in undergraduate program. So she is asking that previously Dr. Ashita here said that you prefer the parents to accompany their children in the dental office, but how do you manage to do your practice when facing over authoritative parents who lose their temper during their child's tantrum, even though they have been advised by the front desk beforehand? Thank you.
Okay, so it's the over authoritative parents, and the child is basically reacting to the parents, correct?
Yes.
Yes. I think this is, I don't normally see this because normally I'm more authoritative than the parents. having, having said that, okay, you always need to communicate with the parents well. Like I said just now, as a dentist, we've always been taught behavior management for the kids. But now we need to really manage parents and their expectations. Okay. So if there are certain ground rules. I think it's important to like just now, when before coming into this chat room for this Zoom meeting, there were some ground rules. I think it's important for you to set some ground rules in your practice. Correct? So you have to tell the parents that in this practice, yes, we want you to be here to support your child, but I am the clinician and the child has to learn to follow my instructions. Okay? Because if they are going to be following your instructions, they're going to be fighting with you. I cannot get my work done. So your job here is just to support me and not tell the child what to do. Because very often if the parents want to tell the child what to do, they tell the child wrong things and different things, and that doesn't help. Okay. So set ground rules, not just for the child, but also for the parents. And I think as a specialist, it's a bit easier probably. But as you go along, when parents realize that you are an experienced clinician and know what you're talking about, right? They will be able to understand your point of view.
I see.
I hope that helps.
Okay, thank you, Dr. Rashida here. And then for the third question from Dr. Ardianti. Dr. Ardianti is one of our staff in pediatric dentistry, Erlangga. So according to your explanation that we have to do the behavior management. So if the doctor is already explained to the parents in pre-appointment about the possible behavior management technique which might be applied during dental visit, should it also be mentioned in informed consent to avoid later problems with the parents? So not only by the explanation, but the written informed consent.
So written informed consent, in my opinion, I don't take it unless it's for pharmacologic behavior management methods. Okay. For non-pharmacologic behavior management method, I take it as an implied consent. Meaning, I've already told you, you come to my office, I am going to do this, because it's implied that you agree to what we have discussed. Okay. But when it's pharmacologic, it is very necessary to take the informed consent in terms of written consent.
Okay. Thank you. Another question from Dr. Dian Lupita. So she is a resident from the Pediatric Dentistry Department. Okay, Dr. Dian has two questions. So the first question is, some patients tend to need multiple visits before he could get the cooperative, especially for young children.
Yeah.
But some parents were not that patient and sometimes they force dentists to finish the treatment in the first visit.
Yes.
Should we separate them and how do you solve this situation?
Okay, I take that question first, Ken, before I forget.
Yes.
So patients coming to my practice, okay, patients coming to my practice will only come to see me for the first visit for a checkup, x-rays and diagnosis, and then treatment plan, and just acclimatization. I do not do treatment at the first visit. Okay. Parents will say, but there's a cavity. But I say, I know there's a cavity, but I didn't know how serious the cavity it was before. So I did not give you the time to fix the tooth at that very visit. You need to have a proper time to have the treatment done. Okay, unless it's an acute emergency, no other choice. Like trauma, for example, there's a fracture or there's a facial swelling. Okay, and very often that also just requires some antibiotics. Okay, so I do not normally do treatment at the very first visit. Why? Because I will always tell them, I need to get to know your child, and that's how I can make him cooperate. I tell them, if I do this procedure today, just rushing into the treatment, it may need maybe 5 minutes, 10 minutes of your time, but it may frighten the child for the rest of his life. You want that simple treatment, 5 minutes, 10 minutes, or do you want to frighten the child for the rest of his life? Many parents actually will understand that view, in my opinion, and that's from my experience. Okay, when you explain it properly, and rushing into treatment doesn't help children. Really, it doesn't, because it's their first time at the dentist. You need to create, remember, a good perception of the dentist and the dental treatment. Once it becomes negative, it will be with them almost for the rest of their lives, and that defeats the purpose.
So we have to educate the parents as well.
All right.
Okay, for the next, the second question from Dr. Dian Lupita, what should we do when parents started getting violent and do physical abuse to their child in our practical room if their child was not cooperative? Sometimes it happened, Dr.
Okay.
Rashid.
I'm glad it doesn't happen much in Singapore. I think you should, but I have seen a parent, this was a long time ago when I was a younger specialist, a parent using rubber bands, rubber band, start flicking on a child. And I actually said, stop. You have to stop that. Actually, in many developed countries, if you note that the parents are actually hitting the child, and as a healthcare professional that takes care of children, you actually have it's your responsibility to report that, okay? Yeah, it will be very messy. So please stop it. Please stop them and say that does not help the child. The child is just going to cry even more. The child is going to be fighting even more. How do you think that actually we can do the treatment? It does not solve the problem.
Right.
Okay? But if it goes on, and I think you should, as someone who champions the rights of children, should report it.
Okay, so we are the pediatric dentists. Okay.
You have to.
And then from the question from Dr. Andi, so he is also the resident of Pediatric Dentistry Specialist Program. In this pandemic situation, we must use mask in all time in the practice room. So if we smile, it is unseen of the patient. So what can we do in this situation to appear our charm to the patient? Thank you very much.
Actually, even if you put a mask and you smile, you can see in my eyes.
All right, right.
No, I think so. We use words, right? And the words we speak to children. And I still remember this. One of my consultants in the UK will say, when you speak to children, you cannot be talking in a monotonous voice. To sound happy to children, you must raise your voice. In speaking to children, the voice must always be, hello, hi, right? So you express it in the way you speak to children, and you must genuinely feel happy. If you feel down, hello, the child will know that you are down. Okay, so you need always to be happy when you speak to children, and they will know the sincerity that comes from it.
Okay. Another question from Dr. Fania. She is also the resident from Pediatric Dentistry. I would like to ask, so before Dr. Rashid talk about the importance of communication, what should we do if the parents keep interrupting while we are doing the explanation? Thank you very much.
So this is when I assume that you are talking to the child and the parents keep interrupting. I am actually quite serious. I would say, please stop, because you are telling him the wrong things to do. So example, I can give you an example. When, sometimes you do procedures on the first quadrant, right? On the molars. You know that sometimes when opening wide, the cheeks actually tighten and it's going to be difficult. Some parents will say, open bigger, right? Yeah. So I will say, no, you shouldn't be telling that to your child, because it doesn't help It's actually the wrong instructions. Okay, so tell them, please do not do that because you are giving the wrong instructions to the child. You make my job more difficult. You make it more difficult for your child too.
Okay, so we have to straight.
I
And
think I think communication. Yes, we need to have a module on managing parents and anxieties and
yeah,
communicating with
I,
parents. Right?
I think we have to get that knowledge as well. And then another question, oh, from Yuvita, Dr. Yuvita, also from the resident. I'd like to ask you about the pharmacological behavior management. Do you using it to your patient? And in what stage, as doctor, we think this kind of non-pharmacological behavior is not effective? And when we should start to decide using the pharmacological one? Thank you.
All right. Okay. So there are instances where pharmacologic behavior management becomes inevitable. Okay. Especially in the pre-cooperative age group. Remember just now I say age of cooperation normally comes from about 4 years old and above. Why? Because their cognitive skills, cognitive development, language development, fears have already gone down. So children below 4, I'm always a bit careful with behavior management. Yes, we assess them. We do assessment of the child's behavior. We assess the need, the dental need, the dental treatment needs. If it's simple 1 or 2 surface fillings on 1 or 2 teeth, no big deal. Maybe you can try. But if it's multiple pulp therapies, 8 pulpotomies in 8 molars in a 3-year-old child, honestly, do you think you can do quadrant dentistry with local anesthesia? I don't
Cannot.
think so.
Yes,
Therefore, you may need to do pharmacologic behavior management, which normally needs a general anesthetic.
I
Okay,
see.
so it's not just the behavior, the age, but it's also the difficulty of the treatment. Okay. But there are instances where children who are 6 years old, okay, may need 1 or 2 pulpotomies, not up to 8. And you have done your acclimatization. So first visit, checkup, x-rays, polishing. Second visit, supposed to do pulpotomy, LA pulpotomy. You put in the LA, already start screaming. Okay,
Hmm.
you know there's going to be a problem. That's where you may want to consider again, um, because the child is not able to cope and the treatment is difficult. So you may want to consider using pharmacologic behavior management. But in this case, if it's 1 or 2 cases, two incidents or teeth, you may not need the general anesthetic. So what do you use? You can use nitrous oxide sedation. So that's something that we would consider. Okay, so it's not just the behavior itself, but it's also the difficulty of the treatment, the complexity of the treatment, right? Even if a child is 10 years old and is cooperative, there's a buried mesiodens, right? There's a buried mesiodens. Would you be able to do with just local anesthesia? Probably not. You may need pharmacologic behavior management, correct? No other specialties. Example, you have an ingrown toenail or a nail. You go and see the surgeon in a child. They will always put the child to sleep to do it. Dentists are expected to do wonders. But even then, we are good at it. We are really good at it. But certain procedures are difficult for children, and we need to acknowledge that.
I see. Okay, but are there any age limit? Maybe less younger children that than 3 years old. Maybe we cannot do the general anesthesia or.
I think general anesthesia is safe.
Hmm.
Um, if a child needs a general anesthesia at 2 years old, he or she needs the general anesthesia at 2 years old. But okay, having said that, if the parents are uncomfortable with the general anesthesia, okay, we want it doesn't mean that the parents want it, right? So I do not want general anesthesia. What can you do? That's a separate discussion altogether, right? So then we have to look at alternative treatments.
Yes.
So that's why nowadays I don't put children to under general anesthesia too early too. Correct? We do buy time, and we know now that we can manage caries, especially with silver diamine fluoride, to buy time. I'm not sure whether it's available in
Yes.
Surabaya in Indonesia now. I hope SDF is available. It's something that I like. I buy time. But we know we still need the general anesthetic. There's no running away from it. When the child is 3 years old, you still need the general anesthetic. The SDF just buys time to avoid the general anesthetic in very young children. Yes. So I do general anesthesia even as young as 2 years old sometimes. But if we can buy time, yes, we do buy time until they are a bit older. Yes, 3 years old, 4 years old before we put them under.
Okay, we still have several questions, so let me check, Dr. Rashida, are that question may be same. Uh, um, if a child had traumatized with dental treatment and cry even just in front of the door,
Yes.
so as pediatric dentist, what can we do to help?
That has happened, right? Children coming in after previous difficult treatment. It's very sad to see such children. And I think you should work hard to try and get them to learn to cooperate again. And that will be very rewarding for you. So again, go back to the basics, right? Understand what was the issue. There is actually acquired fear. Acquired, they get it. Where did they get it from? From a previous past experience. Then you look back at how this child is the level of development, whether you can appeal to his understanding that, hey, we're not going to do the same thing. We're not going to do the same thing. We're going to be much kinder, right? And you project yourself to be kinder, nicer, someone who wants to help, right? And of course, it can be done, right? So you go back, take a step back. Of course, you cannot rush into treatment. And you also need to manage the parents again and their expectations. You cannot be rushing into treatment and getting everything done, because now you really have to heal his behavior, heal his emotions, and that takes time.
Okay. The last question, according to the presentation, there are several technique for the management behavior, Dr. Rashid Tahir. So the management behavior, you see the distraction and then the positive behavior, and which do we have all that management behavior one at a time, or
Good question. It's not one by one. You do all at the same time. You see, behavior management is not you apply one by one by one, right? So now you know you have a whole list of instruments. Okay, now which one is going to work for you, right? The tell, show, do definitely you need, right? The motivation and the rewards, right? You need to give it at the end, right? The distractor, you need to have the distraction. The contingent escape, you use the whole works whenever you treat the patient. You
I
need to find what works best for that particular patient. So it's not just one item.
okay, thank you. The last, in very, very last question from Dr. Seno Pradopo, about the use of the midazolam syrup,
Yes,
Dr. Rashid.
yes. I think not many people use midazolam syrup. I don't know whether you guys use it. Do you use it in Indonesia?
Yeah, Dr. Seno Pradopo, use it.
Okay. Okay. I use it. In my practice, I have 3 pediatric dentists. Now all 3 of them use it under my supervision. Okay. So I use oral midazolam as one off, meaning I don't use for quadrant dentistry. No. Okay. Nitrous oxide I use for quadrant dentistry. Oral midazolam I do not use for quadrant dentistry. It's one off. So meaning one tooth extraction because of abscess, because of trauma. And midazolam effect is very short. So normally I give it 0.5 milligrams per kilogram body weight. Is 0.5 milligram per kilogram body weight. When I give it, I mix it with paracetamol and I make the child wait for about 30 minutes. During that 30 minutes, I make the child slow down because midazolam has 2 effects. Number 1, it can make you slow down. Number 2, it can make you feel disinhibited. That means you get hyperactive. So I tell the parents it's like giving a child some alcohol. So you either become a good drunk or you become a very bad drunk. So you want a good drunk. So they sit down, they read a book until they're a bit tired, they're a bit sleepy. Then they sit down on the chair. We give local anesthetic, we do the treatment.
I see.
We expect the midazolam half-life to be about 4 hours, 3 to 4 hours. So after that, upon discharge, it should last about 3 to 4 hours. They cannot go, they cannot walk on their own because they will fall down. So falls, risk of fall is real in sedated children with midazolam. So they need to go home and sleep it off. They cannot go playground, they cannot go swimming, they cannot go running for that day. All right, and it will go off. And I find it's quite predictable. I like it in for very young children. So these are for very young children who cannot cooperate and breathe from the nitrous oxide gas for the whole length of the procedure.
I see. Okay. Okay. Thank you very much, Dr. Rashid,
Thank you.
for the answer. Dr. Sena Pradopo, is it enough for the answer?
Enough. Thank you, Dr. Rashid. Tahir.
Thank you, Prof. Seno.
So I think we have limitation of time and we have arrived at the end of the lecture. Before I turn the session back to the Master of Ceremony, I would like to thank you to our team from the Pediatric Dentistry, Dr. Ilvana. Wave, please, for the Master of Ceremony. And then Dr. Puspita as well as the host. And then Dr. Barnabas. Dr. Barnabas, where are you?
I can see him.
Please say something.
I hope we can visit you. I don't know when,
Please come.
where, and sometimes later after the pandemic. Thank you very much for the nice presentation and lots of question and answer. Maybe we have to, not maybe, we should meet another time with the another topic with all the students and the residents. Uh, so I will return the session to Dr. Ilvana, please. Thank you.
Thank you, Dr. Tanya, and also thank you to very much to Dr. Rashid for the great sharing knowledge here with us about behavior management. That's really useful and really helpful to us to manage our pediatric patient, I think. And I hope so with Dr. Tanya. Maybe we are hoping to see you again, doctor, not only in online, but maybe you can visit our Faculty Dental Medicine of Erlangga. And before we end of the section, we can take picture together. And
Take picture.
please, yes, we will take picture together, Dr. Rashid.
Okay.
Okay, Mbak Ayu, mungkin saya bisa dibantu Mbak Ayu to give instruction to us about take picture.
Okay, for all participants, please open the video. I will take X slide. Slide 1. Say cheese. 1, 2. It. Slide 2. Cheese. 1, 2. Okay.
This is so funny.
Slide 3. 1, 2. Next. Slide 4. Okay, slide 5. Then next, slide 6. Okay, slide 7. Okay, the last 1, 2. Okay, thank you very much.
Thank you very much, Mbak Ayu. Thank you very much, Dr. Rashid. Finally, from the deepest of my heart, I do apologize if there were mistakes, especially for me. And thank you very much for your kind attention. Thank you very much to all staff of Dakota and WC, and also thank you for all head of dental medicine of University Erlangga, and thank you for all senior colleagues, all students, and all residents. See you in the next event. Wassalamualaikum warahmatullahi wabarakatuh, Dok.
Waalaikumsalam. Thank you so much, Dr. Rashid.
It's a pleasure. I really enjoyed this. Thank you.
It's a great honor to have you this afternoon. By the way, doctors, we still need to have your sign for a specific
Okay, so
program.
the slides, I'm gonna have to remove the photos and then I
Yes.
send it to you by PDF. Is that all right?
Okay, that's great.
I'll do it later.
And also I'll send you the a form that we need your sign to contact
Sure.
this. Thank you so much.
Thank you.
Thank you so much, Dr. Ashita here.
Pleasure, pleasure. Very happy to do this.
We need next session with the pharmacologic.
Yeah.
And then
Please do, Dr. Rashid.
parent management.
But I just you can do midazolam. Can you do nitrous oxide now? I have piped in nitrous oxide in my office now. You know, I have if we open this, Linda, I show you for a while since you guys are still around.
Thank you.
I have my wife still here with me. I'm not sure if you can see.
Nice to meet you.
Hi.
So we have a nitrous.
Good evening, maybe. Oh, I see.
So we have nitrous oxide system, and all the rooms are actually equipped to do nitrous oxide sedation. So I have 3 treatment rooms. They are all ready to do nitrous oxide anytime.
I see.
So I find that it's quite good. My junior specialists enjoy using it. They use it quite a lot. So I think it's really very useful. And there are no adverse reactions. There are no known mortality with the use of nitrous oxide. So I really hope you can get on to use nitrous oxide in Indonesia soon.
Yes, we hope so as well. So Dr. Ashita here, the audience with the virtual background like mine is the resident of the pediatric dentistry.
Okay. I was wondering what it was.
So we are hoping that we can see you later in another session, live session. Maybe you can visit your dental office as well if we go to Singapore.
Anytime.
It's very, very, very near actually, but unfortunately the pandemic has found
It's very challenging. And I hope every one of you will stay safe and take care.
Yes, you too.
We'll get together one day.
Very valuable knowledge. So we have to underline and read and then try and then do our best to do the management behavior since it is our, this is our specialties in pediatric.
It is our specialty, yes.
Yes. Thank you very much
Thank
for
you,
your time.
Dr. Rashid.
Terima
kasih, Prof. Seno.
Okay, bye-bye everyone.
Terima kasih. Thank you very much.
Assalamualaikum. Please stay safe.
See you next.
See you.
See you.
See you.
Terima kasih.
Terima kasih semuanya.
Oke, izin meninggalkan tempat.
Boleh,
Bro.
boleh.
Terima kasih dokter.
Terima kasih Mbak. Terima kasih Uisi, Dokter Irma, Dokter Seno. Prof. Seno sudah. Dokter Ugi. Terima kasih banyak. Semua residen terima kasih. For the next, apa yang harus dilakukan ya Dokter Irma? Mohon arahan. Tinggal ngirim form untuk berita acara gitu ya? Langsung live aja katanya. Baiklah, see you, thank you. Dokter Barnabas, Dokter Ayu, Dokter Ilvana, Dokter siapa lagi ya? Semua, terima kasih residen. Yuk.
Terima kasih dok.
Ilmu. Yuk. Assalamualaikum. Dokter Rere, terima kasih Uisi.
Sama-sama dok.